Professor San Miguel, your group has presented an update of an important portion of patients with myeloma, patients with asymptomatic myeloma, and your group was the first to perform a trial, a randomized trial, focusing in patients with so-called high-risk asymptomatic myeloma. Based on your data, I think that you probably still recommend observation outside the clinical trial.
No doubt.
Okay.
And it's the same as the maintenance. I think prudence is very important in medicine. And although the trial is positive and is really encouraging trial, the standard for the smoldering should be to wait until progression. But saying this, I think is now being more and more recognized that within the smoldering myeloma, the asymptomatic patients, there are at least two different populations, if not three. One are the patients that you should not call myeloma, neither a smoldering myeloma. You should call probably NGAS because the risk of progression.
But you cannot identify them at diagnosis.
I think we are now more close to identify these patients. If they have any of the three risk factors, they have a rate of progression of 1%, at least in our hands. By contrast, there is a group that is high risk. In this group of high risk is in the group that we should do the investigation. But this investigation.
Yeah, I think what your study has shown us is that we have to focus specifically on those high risk smoldering myeloma patients, and we have to see them regularly in short intervals in order to capture, let's say, progression as soon as possible.
And to do a more thorough evaluation.
I think that is one of the important messages, and one should speak it out. Yeah.
Probably these are going to be called early myelomas, and the other will change the name in the future.
Yeah.
And that's one reason why, for example, in the new European intergroup trial, these patients will be registered and followed and diagnosed.
Absolutely, that will provide an opportunity to study prospectively in a large cohort of patients. Professor Sonneveld, what is your current definition of high-risk myeloma and of ultra-high-risk myeloma?
Okay.
Based on probably means that most practicing physicians have.
Yeah, so let's first talk about clinical high-risk myeloma, which we have known, of course, for a number of years. Patients with rapidly progressive disease, patients with renal failure due to myeloma, patients with fractures that need to be treated, and patients with deep anemia or hypercalcemia, all those aspects of aggressive myeloma. I would still regard them as aggressive high-risk myeloma at this time. In addition, over the past years, we have got the availability of additional assays like FISH and chromosome analysis, which shows that there are subgroups that are associated with a high risk. And this changes all the time. So if you are asking me what's the current opinion, then I would say there are a number of abnormalities like 70p deletion, the 414 translocation, patients with abnormalities of chromosome 1 that are associated with high risk. But there is let's say, a trend in clinical trials that with some treatments you can overcome or bypass some of the
high risk to intermediate
of the risk of these high risk features. And the 414 translocation is one of those that can partly be overcome.
To intermediate.
If I am allowed just to add to this, for me, an ultra high risk patient is the one that after an optimized induction and a transplant saw a rapid relapse within the first year.
Yes, but
for me, this is a patient that you don't identify a diagnosis, but for me, this is a patient that you should do for him.
Absolutely right. I was still discussing diagnostic features. And then I think there will also be a future development because now based on gene expression profiling, which is a much more elaborate technique, of course, you can identify and separate high-risk patients from very high-risk patients based on the biology of the disease only. And I foresee that in the coming years this will be introduced in the clinic.
So, Dr. Ludwig, how you can identify prospectively your patient who has a likelihood to live 2 years or less at diagnosis with the means that are available to you today?
I think that has already been mentioned more or less. I would of course look at LDH. High LDH is of course an important risk factor. The patient has frequently severe anemia, has frequently...
But I don't think that a renal failure, for example, today, and you have much more experience and you did a great study, I mean, with the bortezomib-based treatment, I mean, is not anymore an adverse prognostic factor.
If you are able to reverse
it, which happens in about 70% of the patients.
But I was talking about anemia, LDH, bone disease, extramedullary disease, and the rare
17P.
cases, 17P, and
plasma cell leukemia.
What is important, plasma cell of course, and what is important when it comes to cytogenetic abnormalities, a combination of adverse cytogenetic abnormalities is probably an indicator of very high risk.
If you have 17P, it matters.
14.
If you have something
if you have 17P plus 14, then you are really a high-risk case. So if you have 17P plus abnormality and chromosome 1, so the combination of cytogenetic risk factors is probably a very untoward negative prognostic feature.
And the combination of cytogenetic or FISH abnormalities with the ISS, as Dr. Athens also has shown.
So, Dr.
And just put on top of that extramedullary disease.
Yes. I mentioned extramedullary.
Yeah, no. About just to recapitulate these three features.
Yeah, we talked about plasma cell.
So, Dr. Sonneveld, what is your recommended treatment for a patient with ultra-high-risk myeloma? I know that this is a tough question, that we don't have very many trials that have focused in these patients, but what you would recommend to as a consult to a physician who asks you about such a patient?
Well, independent from whether it's just clinical features or
let's say it's a 50-year-old patient who comes with 3,000 plasma cells in the blood and he has a 17P deletion.
That's really unfavorable, yes.
Yes.
So this patient has plasma cell leukemia and 70P deletion, and in fact his myeloma is a genetic disarray. So I would first start treatment fast, the same day, and treat him with a bortezomib-based regimen, triple drug regimen for 3 or 4 cycles, go to a high-dose therapy and autologous transplant regimen, and then proceed, if possible, to an allogeneic transplant as soon as possible after that.